Chapter 16. Chapter 16 is airway management, ventilation, and oxygenation. This is the primary chapter we're studying here for week 2. The content in this chapter mostly is review, but a lot of it we maybe are taking to the next step, so making a little bit more detail into it than what you maybe have previously learned. I will remind you that listening only to this lecture and not reading the textbook is not recommended. You must read the textbook. Some people choose to read the text after watching the lecture and then taking notes in that perspective, but as long as the textbook gets read so you get all of the details, because this is not an exhaustive lecture giving you everything that you're going to possibly need to know in this chapter. All right, so our advanced EMT education standard states that the advanced EMT will be able to apply knowledge of the upper airway anatomy and physiology to patient assessment and management in order to ensure that a patent airway, and adequate mechanical ventilation, and respiration for patients of all ages. Note that third line there, third from the bottom, I guess fourth line down, ensure a patent airway. Patent or patent means a good and clean airway. That is not supposed to say patient, so patent or patent airway. There are a couple of multimedia videos you can watch from the regular PowerPoint slideshow talking about oropharyngeal airway insertion as well as nasal cannula. Our objectives you can cover from reading in your textbook. There's a significant number of those on pages 370 through 372. It's a pretty important chapter that we're going to discuss here. So we'll skip forward through those. Like I said, just a few of them. All right, in introduction, the function of the respiratory system. Why do we have a respiratory system, and why are we concerned with it? Well, obviously, we need oxygen. We've covered that before already, and you should well know that the body needs oxygen as one of its 3 primary building blocks for metabolism. And it also needs to eliminate carbon dioxide that is produced as a byproduct of cellular metabolism. So I want you to stop for a moment and consider this. Consider that you can continue to bring all the goods in, all the groceries, fresh air and whatnot into the house as possible that you live in. However, you can never take out the garbage, flush any waste, anything like that, and you can't get rid of the stagnant, stale air that stays in your house. Imagine how that would affect your life. This is the same thing. We have to be able to bring in the good and take out the bad. And so this cardiovascular system in conjunction with the respiratory system do this. Respiration is the gas exchange that relies upon microscopic anatomy of alveoli, capillary, and principal gradients in order to move air and gases from one spot to another. Respiration is gas exchange. So I disagree with what we commonly call one of our vital signs, respiration. I don't feel we should call it respiration because we can't guarantee that that actually is respiration. We should refer to it as ventilation because that's what we're doing. The difference between ventilation and respiration is ventilation is a movement of air in and out of the body. Respiration is the movement of air back and forth into and out of the cells. So it's always a source of fun debate to discuss that. You can ventilate a freshly dead body for quite some time, but it doesn't make any respiration occur. So we can move air in and out, in and out, in and out, but to actually make it go around and around and around to the cells, we can't guarantee that. So respiratory support for metabolism requires the mechanical process of ventilation, and ventilation requires or relies on an open airway for airflow in and out of the lungs. So we need to be able to move the air, and that is ventilation. So we often have great influence over ventilation. We try to assist respiration in occurring, but we're not always successful in doing that. Provided that we can get an open and patent airway for a patient, we can usually ventilate them fairly well. There's always going to be impedances and other issues that pop up, and that's some of the things that we fight against as advanced EMTs. Problems with any aspect of ventilation or respiration can quickly result in death, and AEMTs are skilled in a variety of techniques from simple and non-invasive to more complex techniques to help assure ventilation and respiration. So with that being said, we'll stop for a moment and consider what are some problems that could potentially be a problem or an issue with ventilation. And the number one that should come to mind is a foreign body airway obstruction. Foreign body airway obstruction. So a piece of food, a toy, you've bitten off your own tongue and it's lodged there. So there's several things that can obviously impede ventilation. Now, we can take it that interferes with airway. We can also have some illnesses that interfere with airway, illnesses that cause swelling and cause the patient's airways to shrink. That can be airway issues. We can have mucus, blood, and whatnot in the airways, and that kind of clams things up a bit. So in those cases, we may have to do some other things to help open airways, to clear airways, to unclog them, and perhaps even dilate them. So those are a number of things that we have to consider. Ventilation, furthermore on ventilation, we go to breathing, the B side of things. How do we affect breathing? How does air get in and out? Well, air goes in and out via a vacuum. That vacuum is created by muscles and tissues and the tissue relations and contacts that they get. So we may be talking about a person with a broken rib cage. So you bust up a rib cage, you don't move air in and out because it disrupts the way that the vacuum operates. So you may not be able to move air easily that way. Additionally, you may have patients who have a pneumothorax, and a pneumothorax is when you have the linings of the lung not in the right spots, and it causes the lung to collapse. If that lung starts to collapse, air just does not move in and out like it normally should. So that's another case in which ventilation may be disrupted. We also may have things such as a blockage somewhere along there, or we have alveoli that don't work. That can impede ventilation. And then respiration, the respiration side of things. Maybe we have water accumulating between the alveoli and the capillary. That's where the gas exchange is supposed to take place. Well, if we have water in between the alveoli and the capillary, it makes it much harder for the air to just, or the gases, to easily move across one way to another. So we have to be cognizant of that when we have certain medical conditions like congestive heart failure. A patient with congestive heart failure may have extra fluid buildup, and that extra fluid buildup then becomes a barrier for gas exchange. So definitely something to keep in mind. Maybe we can't get the blood all the way out to where it needs to go. Perhaps the blood needs to make it to the toe or make it to the elbow or something like that. But the patient is shocky. The patient has hypoperfusion because they don't have enough blood in their system. And when this occurs, then the patient maybe doesn't perfuse well, and therefore they never get the goods in and the bads out. So that's just a few of the more common problems that we would deal with. So airway and ventilatory management requires you to use critical thinking and clinical judgment. And some things to consider would be the patient's condition, the amount and type of help available, the factors that may complicate the situation, and the amount of time for an option must work for the patient. So some of these things to think about. Patient condition. Well, should we put the best airway that most advanced EMTs have is either a combi tube or a King LT airway. Either of those things are very good airways. They tend to work very nicely. They're fairly simple, but another thing to consider is, does that patient truly need that big and bad of an airway when maybe we can get by with something else? We'll take, for example, a diabetic patient. If we have a diabetic that's hypoglycemic, their blood sugar has dropped, and while their blood sugar has dropped, we decide, oh, well, we can fix that, but ABCs come before IVs and sugars, so somebody decides, well, we better slam a King airway down this person. We put a King airway down their throat, we blow up the balloons and all this, and then we, in the meantime, we get an advanced airway, or we get an IV in them and give them an amp of dextrose 50%. Their blood sugar jumps back up, and now all of a sudden the patient wakes up. And oftentimes it is that quick, within minutes, 2 to 3 minutes in many cases, from giving them that IV sugar, that bam, the patient is waking up. So now we have a patient waking up with this tube jammed down their throat. Well, any of you guys who have ever had somebody look at the back of your throat and had that tongue depressor go back there that gagged you, it's very, very possible that this patient is feeling this to about the 10th power. So if that's the case, we need to strongly consider, on patients that we may fix quickly, drug overdoses included, that maybe we went a little too far. Maybe it's a little too much for what this patient needs. So can we get by with something a little less dramatic in order to get this patient woke back up? The amount and type of help available. Are we going to have enough hands that we can continue to do the vital signs and splint the arm and carry the backboard and so on and so forth if we take somebody out of the way to do nothing but hold their airway open, or somebody's going to be tied up for a couple of minutes doing an advanced airway? Do we have any factors that complicate this, such as they shot themselves in the face and now there's holes all over their face that we're going to have a difficult time maintaining mask seal? So maybe they shot their jaw off and we use a King airway, we can control that. And then the amount of time it needs to work for the patient. If we simply need to keep their airway open while we're waiting for their sugar to kick in from the D50, maybe just a modified jaw thrust or maybe a head tilt chin lift will work for us. Or we can use something a little bit more advanced, like a nasal pharyngeal airway, which doesn't tend to cause the gag reflex to kick in. So we can use that nasopharyngeal airway as they start to wake up. All we have to do is pull that out real quickly. There's no deflating or anything. It's slightly uncomfortable, but bam, it's out and no big deal. So those are some thoughts. So to look at the respiratory anatomy that we've got here, we have the upper airway, which is everything from the epiglottis up, and we have the lower airway, which is everything from the epiglottis down, and those airways have kind of some very distinctive differences. Upper airways tend to be much more soft tissue base. Not that the lower airway doesn't have soft tissue, but there tends to be cartilaginous rings and things that make it semi-firm, semi-rigid, as opposed to the upper airway, which is generally pretty pliable. All right, so how would you describe the general impression of the patient? So this, again, refers to your think about it question that we had from your case study on page 371. I'll let you guys answer those questions. And we will see this case study again later. All right, so when we're talking external respiration versus internal respiration, external is that respiration that is exposed to the outside world. So when we say you breathe outside air into your lungs, that is the external respiration. Well, that's actually external ventilation, because the external respiration is when that air that's in the alveoli moves into the capillary, and the waste product in the capillary moves then into the alveoli. So it is that is exposed to outside influences. So room air, oxygen from the non-rebreather, that is the external respiration side of things. So the internal respiration is on the other end. So after it has left the lungs and moved via the circulatory system to your toe or your elbow or your nose or whatever, that's where the internal respiration is going to occur. Then the oxygen gets out of the capillary and goes into the cells, and the carbon dioxide and waste products come out of the cells and get back into the alveoli, back into the capillary, and then is moved back up to the lungs, where again external respiration will occur. Bad stuff gets out of the blood and into the alveoli, the good stuff gets out of the alveoli and into the blood, and the cycle just continues, at least in theory. So the physiology of air movement. Ventilation is controlled by the levels of carbon dioxide, CO2, and oxygen, O2, in the blood and the cerebrospinal fluid. So most people operate off of a system of high carbon dioxide. When your body senses carbon dioxide gets high, this is the hypoxic or the carbonic drive. When you become hypercapnic, which is the term for high CO2, your body says, let's get rid of it. So take a breath or kick up the respiratory rate. We're not doing enough. So that's how the most people's respirations are triggered. People with COPD, which is emphysema, chronic bronchitis, those people breathe off of what is referred to as the hypoxic drive. And the hypoxic drive is the backup mechanism that says, well, we didn't trigger increased ventilation for high CO2, so the backup mechanism is when the oxygen level drops, that's the backup trigger. Well, people who have COPD and have smoked a lot, been involved with various toxic environments for long periods of time, they've knocked out their hypoxic or their hypercapnic drive. Their main trigger has basically been disabled. So they rely on their hypoxic drive, which is that low O2 level. So those are the, and there's chemoreceptors and baroreceptors, chemo for chemicals, baro for pressure, receptors found several places around the head and neck that will sense the levels of CO2 and O2 in both the blood and the cerebrospinal fluid. Those chemoreceptors signal the inspiratory center of the medulla oblongata in the brain stem. Remember that, because we'll be touching on that when we get to the anatomy and physiology chapter. But it triggers that area in the medulla oblongata, and when those carbon dioxide levels are high or the oxygen levels are low, and it says go ahead and breathe. The inspiratory center stimulates the contraction of the diaphragm and intercostal muscles. So a signal is sent usually via the phrenic nerve and a couple of accessory nerves that go down into the chest, and the phrenic nerve runs the diaphragm. The diaphragm is then told to contract, so it pulls downward into the abdominal cavity and it flattens out. Remember, the diaphragm is usually dome-shaped, so it pulls downward and flattens out. The intercostal muscles will then also spread and allow the ribs to go outward and upward, creating that negative pressure within the chest, and that was then sucking air in. So the air flows from that higher atmospheric pressure to a lower intrapulmonary pressure. So I'm going to use arbitrary numbers here for this, just simply for the sake of demonstration. Let's say the weight or the pressure, atmospheric pressure in the room is 10 and the atmospheric pressure, or I should say the intrapulmonary pressure within your chest wall when your diaphragm goes down and your chest wall goes out is 5. We have high pressure outside, low pressure inside. Where is air going to go? Because everything in the world is working towards being nice and even and equal and equilibrium, Zen and all that good stuff. But so if it's 10 outside, 5 inside, what's air going to do? Well, it's going to try to rush in and try to even out that pressure and try to make it the same. So when that air rushes in, that is inspiration. So our chest actually runs off of a negative pressure system. That's normal ventilation for us, is negative pressure. A positive pressure ventilation is what we do when we bag somebody. We force the air into their lungs as opposed to their lungs sucking it in and taking it from its environment. So it's a different dynamic. Once the lungs start to spread and get larger as they fill with air, there are receptors in those lungs that send signals to say stop. We have maxed out, don't take it anymore. The diaphragm and the intercostal muscles then will relax. This is often referred to as the Herring-Brewer reflex. So the Herring-Brewer reflex tells everything to say, okay, we've reached capacity, quit, and just let everything relax. And then once everything starts to relax, the chest wall starts to shrink and go back in. The diaphragm starts to relax and go back up to its normal dome position within the chest. That will then increase the pressure in the chest, or the intrapulmonary pressure, and that creates a higher pressure on the inside than there is on the outside. So again, arbitrary numbers again. Remember we said that arbitrarily when we were inspiring, atmospheric pressure was 10, intrapulmonary pressure was 5. It wanted to equal out, so boom, it pushed it out. Or I'm sorry, pulled it in, sucked it into the chest. Now, as everything relaxes and the chest gets smaller, now the pressure rises. So we'll say that the intrapulmonary pressure is now 15 and the atmospheric pressure is now 10. It's remaining steady at 10. So what happens? Some air is going to rush out to try to make them equal. And so that's where the positive pressure exhalation, which is actually a passive process because it's just natural relaxation, kicks in. So to touch some more on the AEMT here, let's look at the upper airway. So we've got, you can see if you look at the laryngopharynx there, about 2/3 of the way down on the list on the right side there, or 3/4 of the way maybe. You can see where it identifies the epiglottis and the vocal cords. That's the separating point between upper and lower airway. It's technically the vocal cords and the glottic opening. The glottic opening is the space between the cords. It's technically the division. The epiglottis is usually what we use kind of as a rough rule because that actually seals off the lower airway from the upper airway. So if we look at this, we have the nasal cavity up in there. Within the nasal cavity you have the turbinates, which create a lot of twists and turns and causes it to moisturize and moisturize and heat the air coming in through the nose. The mouth can do the same thing. It just doesn't have quite the surface area. And the turbulence that is coming from the turbinates helps move it around. It's not stagnant air. Then the air will move into the back of the mouth and nose area there to the pharynx, the laryngopharynx as is referred, or the common pharynx, where it comes then down and it shares. The pharynx is kind of a common tube for food, liquids, and air. It comes down and then is going to go down through the larynx, through the vocal cords, down into the trachea. In theory, sometimes other things happen and something slips in there. Food or water slips in there when it's not supposed to. Typically when we swallow, if you would swallow something, the muscular actions of the tongue and the throat will cause that epiglottis to close down over the top of the vocal cords there and over the top of the larynx. You can see a couple representation of different bones there, how the tongue is mostly attached to the mandible. There's a lot of attachment to the mandible or the jawbone, as well as the hyoid bone helps to anchor the tongue as well. The hyoid bone is the only bone in the human body that does not articulate with any other bone. So it doesn't move back and forth with other bones. It does its own thing. It kind of sits there all by itself. And it's the anchor of the tongue and really kind of the epiglottis. So then we have the larynx represented and the outside there. You can see the thyroid cartilage, the trachea, cricoid cartilage, thyroid gland. Those things represent, the thyroid gland is lower, but the thyroid cartilage itself represents the Adam's apple and the larynx. So, and then behind the trachea, you can see towards the back is the esophagus. So when we swallow, the epiglottis closes, causes the food to come back down there, and it slides right past the opening, because the gate is closed, slides right past the opening to the airway, and slides then by proxy down into the esophagus. The vallecula, this is not something you probably are going to use much, but the vallecula is the space between the tongue and the epiglottis. When paramedics intubate with a certain type of blade, they use the vallecula as a certain landmark there. So our upper airway consists of all the structures above the glottis, or the glottic opening, the space between the vocal cords. Air enters the body through the nose and mouth. Air from the nose enters the pharynx at the nasopharynx, from the mouth at the oropharynx. They go into the hypopharynx and then down to the laryngopharynx. And that provides the passageway, like I said, dual passage for digestive and respiratory systems. During swallowing, like I said, the epiglottis closes over the glottis, or the opening of the larynx, prevents the food and fluid from traveling upward into the nasopharynx, because if we look at that picture again, the areas of the uvula, so the back of the mouth, they mark it as tonsil, they don't show the uvula on there. But that area also pushes upward and blocks off the nasopharynx, so stuff is not supposed to go upward. The cough reflex occurs when inflammation or irritants stimulate the sensory receptors in the linings of the airway. So we have cough reflex sensors everywhere in our upper and lower airways. So it causes us to try to forcefully expel any irritants or any materials that aren't supposed to be there. There's a certain degree of muscle tone required to keep the tongue from relaxing and falling into the pharynx, and it can obstruct airflow. That is the #1 thing that does obstruct airflow, and you may know somebody in which this happens on a very regular basis. When we're talking about people who we're laying next to at night and they snore, that's the problem, is their tongue is, the muscle tone is not there, the tongue relaxes down, partially blocks the airway, and this creates a obviously noisy situation. If the tongue continues to fall back, say we have somebody unconscious, whether it's a drug overdose or what, we have somebody unconscious and the tongue continues to fall back, we have some basic airway adjuncts that will help us with this, the oropharyngeal and nasopharyngeal airway. And then I answered the question right there, what's the most common cause of airway obstruction? It is the tongue. So, all right, to shift down now to the lower airway, we see some representation there of everything from, if you basically go from the larynx down, you're talking lower airway. The carina is the split where the trachea branches into right and left halves going to the right and left lungs. With the main stem bronchi, or the main bronchi, or primary bronchi, or bronchus that they're called, that go to the various parts of the lungs. They break down to smaller secondary and tertiary until they finally get to terminal bronchioles. The terminal bronchioles are the very smallest little branches that go directly to the alveoli. So, and then the alveolus, of course, is the termination of that, the internal respiratory system, where the air or the gases exchange. Now, what they don't do a very good job in this picture of showing you is that the alveoli have little bands around them. It's like if you take the cover off a baseball. It's very similar look. It's got elastic bands around it that help it stretch and relax, as well as blood vessels that surround it. And those blood vessels obviously is where the gas exchange is going to take place. They can expand, they can contract, and that's where the elastic bands come from. So that lower airway begins at the glottic opening, goes into the trachea. The trachea bifurcates to right and left bronchus at the carina, so it bifurcates a split. So bronchi divide into smaller branches. They become bronchioles, leading to that clusters of alveoli. So for gas exchange to take place, external respiration, oxygen moves into the bloodstream from the alveoli. Carbon dioxide moves from the bloodstream into the alveoli, and they cross because of differences in pressure gradient. So imagine this, if you will. Every time blood circulates through your body, you use about 5% of the oxygen that is in it. So we'll say, for example, if we breathe in 21% oxygen from the room air and it goes around your system once, you take 5% of it out, leaving you 16%. Well, if your blood makes one pass and comes directly back to the lungs, you now have 21% oxygen in the alveoli. You have 16% oxygen in the blood. And that sees a difference. The body's like, that's not equal, we want equal. So it starts to, through pressure gradient, push the oxygen into the alveoli, or I'm sorry, into the blood from the alveoli, so it equals out. It's the same process when we talk carbon dioxide. There's a very, very, very minuscule amount of carbon dioxide in room air, and there's a slightly higher amount of carbon dioxide in the bloodstream after it has gone to where it needs to go and is returned to the lungs. So the same thing happens. There's a high level in the blood, a low level outside the blood, and so it tries to equal out. So it pushes some of that carbon dioxide out of the blood and into the alveoli, because there's no, it doesn't show up as hardly any, if at all, carbon dioxide in there. So internal respiration occurs then when the oxygen is delivered to the cellular level by the hemoglobin on the red cells, and the carbon dioxide is released from cellular metabolism and goes into the blood. So let's say it circulates, we got fresh blood, no carbon dioxide, 21% oxygen from the alveoli. It circulates through our body and it goes down to our toe. And the toe is going to say, oh, I've got trash and I need goods, so it makes the swap. So there's that 16% oxygen in the toe, 21% oxygen in the bloodstream, and they swap. It tries to even it out. And then there is minuscule to no carbon dioxide in the bloodstream. There's a slightly higher amount of carbon dioxide in the toe, and so it has to equal it out, so it pulls the carbon dioxide into the blood. And that's how those two processes work. So we're going to define some terms: alveolar ventilation, tidal volume, and dead airspace. So when we're talking some of these topics, we are talking about specifically looking at alveolar ventilation as the amount of air moved in and out of the alveoli. So the air that makes it to the alveoli each minute. So there's a couple other terms that we can throw in here with this, and some of those would include minute volume, and a minute volume is the total volume of air that we move in a breath times the number of breaths per minute. So if we say we move 500 milliliters, which is average, we move 500 per breath times about we'll say just 10, that makes it easy, 10 breaths a minute, our minute volume is 5,000 milliliters or 5 liters. The alveolar ventilation would be a fraction of that that actually makes it down there into the alveoli. So typically around 350 milliliters will reach the alveoli and of a single breath. And then we have another 150 milliliters of air that occupies the dead space in the trachea. So that dead air space is air that's just sitting there. It's taking up space because there's no ability for the trachea and the bronchioles to do gas exchange back and forth into the blood. So it sits there kind of stagnant until it's exhaled out. But it has to be there. Something has to fill the gap. Tidal volume, that's the amount of breath per, or amount of air per breath. So a single breath. And like I said, tidal volume would be then 500 milliliters. The minute volume is that tidal volume multiplied by the number of breaths. Hopefully that clarifies that. When tidal volume decreases, the volume of the dead space remains constant at the expense of the alveolar ventilation. So if we take smaller breaths, so let's say we take a more shallow breath, we very possibly, or we're still going to have 150 trapped in the dead space, but we may now only get 200 milliliters into our alveoli. So we don't change the size of the dead space in most cases. There are a few things, but we don't change the size of the dead space much. So we sometimes will then have to make up for getting less air to the alveoli, and we would then probably increase our rate. So if we go from having 350 milliliters available for alveolar ventilation to 200 milliliters available for alveolar ventilation, we may have to kick up our rate and breathe faster in order to accommodate and still have the same amount of oxygen available to our system. All right, so here's a different thing about it. A trauma patient has an injury that has allowed air to separate the portion of the parietal pleura from the visceral pleura, so the lining of the inside of the chest and the lining of the lung. This is called a pneumothorax, and how will this affect ventilation and respiration? Well, if we have air stuck in there between the two pleura, it puts pressure on the lung. The lung begins to collapse. When the lung begins collapsing, parts of that lung are basically, we'll say, crushed, and they're not able to expand like they're supposed to. So therefore, it wipes out a certain percentage of our available alveoli. This also is going to build up more and more pressure within the chest, which takes away from the chest's ability to expand and contract and bring air in and out. So it decreases the amount of air we can bring in. So the ventilation is decreased, and with alveoli being damaged and out of commission, respiration decreases. All right, before we move on to this, there's an item I want to take just a second on 377 in your textbook, where it talks about ventilatory or ventilation perfusion mismatch, or often called VQ mismatch. And that ventilation perfusion mismatch, this happens when you have blood generally circulating well, but it's not getting to all of the areas. So let's say a blood clot in the lung decreases the ability for the blood to get to part of that lung. So one of the lobes of the lung is blocked off. So the alveoli are still going to be getting, alveoli are still going to be getting oxygen into them, but there's no blood coming by there to pick that up and move it. So it's basically considered dead space. We may also have problems with there being interstitial fluid between the capillary and the alveoli, and that's often what happens when we have pulmonary edema, say from congestive heart failure. We will retouch those topics at a later date, but be aware ventilatory perfusion or ventilation perfusion mismatch is when, even though you may be moving air in and out, you don't always have the capacity to take full advantage of that. All right. Pathophysiology of the airway, ventilation, and oxygenation. So the upper airway, what major issues that we deal with there, the tongue obstructing the oropharynx, and that's going to slow the airflow through the trachea. So patients that are, we'll take example, somebody who is a heroin overdose. A couple things happen here. Number one, heroin overdose. Heroin is a narcotic. Officially, it's an opioid. Opioids decrease the respiratory drive. So if you decrease the respiratory drive of a patient, they don't breathe as quickly or nor as deeply. Then we can also throw in the fact that opioids also create very sedated folks. So we have a very sedated patient, and the patient no longer is able to control their own airway. They may have the snoring respiration. They've already slowed down their breathing. They've already decreased the capacity of their breathing. So they're at a double whammy, having a double whammy that's affecting their ventilation, which is in turn going to affect their respiration. We may have a foreign body airway obstruction, such as a toy, a piece of food, what have you, that completely blocks the airway, where they probably wouldn't have had many issues with oxygenation if they were able to ventilate and get the oxygen actually into the system. We may have active bleeding, blood clots, and other problems to the airway structures. Somebody has a traumatic injury to their face, maybe knocked out teeth, it's broken a jaw, they bit part of their tongue off. All of those things can potentially lead to obstructions and blockages of the upper airway. And additionally, we can have upper airway edema, things from such as burns, an anaphylactic reaction, remember, which is a severe allergic reaction, or infection. There's a number of infections that we're going to start to see popping up again. They happen every year during the cold weather, and particularly in our pediatric population, we see a lot of croup. The croup is an infection, causes some swelling, causes some weeping, or some mucus discharge that narrows the airway, causes them to have a cough, usually they have a fever, and they may be hacking up and have a real seal bark style cough. Burns, just like burns on the outside will cause your skin to swell, they cause your tissues to swell on the inside. And then anaphylaxis, like I mentioned. So here's a good chart regarding respiratory sounds. I would pay close attention to this chart and perhaps circle it or something in your book to pay attention to. But abnormal respiratory sounds, and these sounds can be either auscultated or audible. Audible means you can hear it without assistance. Auscultated means you usually are using assistance of a stethoscope. So an audible sound would be snoring. So a harsh, vibrating, or rattling sound can be loud or soft. The significance of this, it's indicating that there is some sort of a partial airway obstruction, normally the tongue, and the tongue is usually just rattling as the air moves back and forth across it. We may have gurgling, which gurgling is typically an audible sound. This is a liquid bubbling sound, usually indicates fluid in the upper airway. More times than not, you would hear somebody that has vomited or has a lot of blood in their throat, that is laying perhaps on their back and still breathing a bit. You would hear this gurgling. Stridor. Stridor is typically audible, and a stridor sound is a harsh inspiratory squeal, more or less, and it's a partial airway obstruction that can indicate laryngeal edema, a foreign body obstruction, or an epiglottitis, which is essentially laryngeal edema. Epiglottitis is another infection of the epiglottis itself. It's viral and comes on rather quickly. It's kind of a scary situation. But as things narrow up there, things start to squeak and squeal. If you've ever, imagine this, if you've ever seen somebody who's taken a blade of grass and put it between their thumbs and blown between there and kind of got that squeak squeal that comes by that vibrating little blade of grass in between their thumbs. Really, they're sort of kind of creating a stridor. They have a very narrowed passageway, and things are starting to vibrate a little bit in there, and that's going to cause some of that stridor. Coughing, also typically an audible sound. I don't think I need to explain what it sounds like. I think we've all experienced it probably sometime within the last 24 hours. But this is irritation of that mucosa, either from infection, irritants, mucus, whatnot, that is leaking, and the body is attempting to forcefully remove it. Wheezing can either be auscultated or audible, and it is a whistly musical-like sound of the lower airway, and it's often heard on expiration, but can also be heard on inspiration. The significance of this is the narrowing of the bronchioles from edema or bronchoconstriction. Most commonly heard, and when we say wheezing, we most commonly think of asthma. It does not only cause from asthma. Crackles, the more correct medical term for crackles is rales, but it sounds like crackles, so they call it crackles. These are fine bubbles, crackling sound heard in the lower airways. This is going to have to be, in most cases, auscultated with your stethoscope. That indicates that there is fluid in those lower airways. A good representation, if your hair is long enough, take a couple strands of hair between your thumb and your forefinger, pull it right in front of your ear, and just kind of move your fingers back and forth. Roll the hair between your fingers. That is a very similar sound to what crackles or rales sounds like, little bubbles. Then we also have rhonchi. Rhonchi is big bubbles. So rhonchi is a coarse liquid in the lower airways, usually secretions from the bronchi. So rhonchi are in the bronchi. They're bigger. Rales, smaller word, smaller tubes, so they're down lower, typically towards the alveoli or the terminal bronchioles. So they're very fine, and then rhonchi is very rough. So I like to think of rhonchi as that heavy, coarse, thick, mucousy cough that, that's the air bubbling through that mucus. It's very thick, and it's almost like a saw. So bronchoconstriction in the lower airway is going to obviously affect those smaller airways, the bronchioles, the terminal bronchioles, the smaller bronchi. You get some bronchospasm that can occur, where inflammation would be swelling. Bronchospasm is a constriction of those muscles, or you can have both. You might have, and that's usually the case in asthma, is you not only have the lining weeping and swelling causing inflammation as a result of inflammation, but then they're also irritated to the point that they start to constrict or spasm. Gas exchange is going to be impaired by accumulation of fluid or pus in the alveoli or bronchioles. So let's imagine that in the alveoli, which are supposed to be very thin-walled little airbags, we have a lot of thick gunk that is just lining those walls, almost that you painted the inside walls. So you put an armor over the top of it. That restricts the airflow or the air exchange that's supposed to be occurring. Bronchioles can be the same way. They're narrowed up because of this inflammation. Ventilatory problems. Trauma or a problem that interferes with the ability for the chest wall or diaphragm to move. So if we have a spinal injury way up high that affects the phrenic nerve, it may knock out our diaphragm. The diaphragm won't be able to move on its own. Maybe we have a bunch of broken ribs, a flail segment. You'll have to go back and think about that for a second maybe, but a flail segment where you have a whole bunch of broken ribs right in a row. That affects the ability for the chest to rise and expand, rise and expand, rise and expand, rise and expand. That affects that. Maybe we've paralyzed all the muscles that have to do with the chest at all, so they can't rise and expand on their own. Or perhaps the diaphragm has been ruptured from a severe blow to the trunk of the body. Well, if the diaphragm's ruptured, it can't fully function in expanding and contracting. So those are obviously some things that would interfere with ventilation. We may have some other underlying problems, paralysis of the respiratory muscles, which is usually typically a actually nervous system issue where the nervous system cannot send the signals to the muscles. We may have had a stroke, and when the patient has a stroke, it has maybe affected the brainstem and the lower parts of their brain that affects breathing, or the stroke has actually affected the nerves and muscles of the skeletal system. So it's kind of a double whammy. It depends on where the stroke occurs. So a stroke can paralyze muscles on one side of the body, actually can paralyze them on both sides too. So a spinal cord or a neurologic trauma, like I mentioned, you cut your spinal cord in half, that's kind of a big deal. There's no fixing that yet. The chest wall, the trachea, the bronchi, the lung parenchyma. Lung parenchyma is the tissue that fills the spaces. I think of the lungs as a sponge. So the solid portions of the sponge represent the parenchyma, and then the holes in the sponge represent the alveoli. What we don't have represented in the sponge is the bronchioles that are part of that. So the parenchyma can be damaged. You can have a bruise or what's called a pulmonary contusion there. So if we have fractured our trachea, you can fracture your trachea. You get clotheslined. So those of you guys that might be snowmobilers might be out there running around on your snowmobiles and somebody's got a electric fence or something up, and you come along and take it right to the throat. That could fracture your trachea, and by fracturing the trachea, you lose that integrity and air doesn't move as nicely. And drug overdoses, like I've mentioned that in the past. So another thing about it, epiglottitis. Epiglottitis is a bacterial, that's not correct. It's typically a viral infection that causes swelling of the epiglottis, and it can obstruct the airway. It's most common in children and also occurs in adults. So actually I take that back. That is a bacterial infection, my bad. It's croup, this viral. Bacterial infection that causes swelling of the epiglottis, and it's most common in children, but it's starting to affect more and more adults because there was a period in time in which not a lot of adults got immunized to it. So it does affect a few. Epiglottitis comes on like a ton of bricks. It spikes you up a very high fever, and it happens very quickly. And these kids usually are drooling, sitting upright in kind of a tripod position, and they're very, very sick. And it most commonly comes on in the middle of the night. So they will complain of instant, went to bed fine, woke up with a sore throat, they have a high fever, they're drooling, and it's very painful if anything gets into their throat. So with that, if the airway is in jeopardy, the patient presents in a tripod position and may have stridor upon inspiration. Well, what if we were to go and put airways into that? It's already inflamed, and anything that touches it causes severe irritation. So it's very possible that if we go in there and touch that, we're going to cause some extreme swelling, and we may lose our airway altogether. Assessment of the airway, ventilation, and oxygenation. Scene size up. So our patients get evaluated early on in the process for their airway status, their breathing or ventilation, and their oxygenation. Things that give us clues to this include our general impression, whether they're responsive or unresponsive, and then any indications of injury or distress, so mechanism of injury and nature of illness. These all kind of play into that. So general impression, do we feel good about this? General impression is another way of saying gut feeling. It's just one of those we walk in and we go, oh crap. Well, that's a poor general impression. It means we're going to need to probably scoot. Responsive versus unresponsive. Unresponsive isn't always a terrible thing. Some people are always unresponsive, and with more and more people being on home care, we may see more of those. Sometimes people are unresponsive and just difficult to wake up. But generally unresponsive is not a good sign. And then obviously we look at their MOI, NOI, try to make some sense of this. Why would you have shortness of breath from a fall? Why would you have shortness of breath from just hanging around at home and nothing else was a problem? You got to start kind of putting things together and getting more information. Things that we're going to look more specifically at is increased effort to breathe. So are they using any accessory muscles? Are they using the abdominal muscles to help them breathe? Do they have any abnormal breath sounds? Are we talking about a tripod positioning or any cyanosis that they may have? We're going to help try to determine their chief complaint. So what is really the major issue that you called us for? What is the problem that is at hand? And not always is it shortness of breath. Although shortness of breath may be the most pressing issue, they may not initially see it that way until we start talking to them and get a little more info. Then what's the quality of the patient's speech? A lot of times we'll judge that in the number of phrases that they can talk to us in. Can they talk to us in a full sentence before having to take a breath? Or do we get 2 or 3 word dyspnea, meaning they can say 1 or 2 or 3 words, 2 or 3 words before they have to take a breath. The fewer words they can say, obviously, the worse this issue is. And then we have our primary assessment. The primary assessment, we're starting to look at the patient, apparently unresponsive patient. Are they cyanotic or mottled? Do they have any respiratory effort, or are we seeing simply agonal breathing? For those of you guys who haven't talked agonal breathing in a while, remember agonal breathing is, I call it guppy breathing or fish out of water breathing. You take that fish out of the water, you throw them up on the bank. They're going to still attempt, their mouth's going to pop open, they're going to try to get a breath. They can't breathe through atmospheric air. They have to have oxygen from the water, but that's kind of what it looks like. So it's just every once in a while this gasping effort, and that's about it. Then of course we're going to check their carotid pulse. We're going to talk much more about the specifics of assessment in a couple weeks. So an apparently unresponsive patient, we may identify them as a cardiac arrest patient. And if that is the case, we obviously need to start chest compressions, CPR, run down the AED line. Or if we have a sleeping, intoxicated, medical or trauma issue, we may try to get them to respond to a voice or painful stimulus. So starting out with some of our mechanisms here. So we're going to talk about a variety of maneuvers that we can perform on our patients. If we're having a lack of decent respiratory effort, we may have an airway issue, so we may try a modified jaw thrust or a head tilt chin lift, depending on that patient's condition. If we have a suspected trauma patient, modified jaw thrust, where we put our fingers behind the crook of the jaw and push the jaw forward. You're using your thumbs kind of to press on their cheekbones and trying to kind of squeeze together between the thumbs and the fingers to pull the jaw forward and keep the head backward. Remember the head tilt chin lift, this is what we're most commonly used to. A palm on their forehead, a couple fingers underneath their chin, lift the chin, rotate the head back. So if we have this apparently unresponsive patient, we open their airway for them. Remember, don't forget to open their airway. If they're not breathing, open the airway. Assess their airway, their breathing, their circulation. We use the appropriate maneuver, whether it's a spine or not, spinal injury or not, cervical spine. Mobilization kind of goes along with that. So if we're using a jaw thrust, we're going to be holding C-spine kind of at the same time. Otherwise, our head tilt chin lift. We can also use the trauma chin lift to open the airway of a trauma patient. And the trauma chin lift is a lot of times just grasping that lower jaw and pulling it forward. So it's grasping the mandible by inserting the glove of or thumb of a gloved hand in the patient's mouth, behind the lower incisors and placing the index finger under the chin and then just pulling upward. You can actually cause their head to rotate back, so it's not highly recommended. Additional adjuncts that we need early in the process of assessment are going to include suction. This is an example of a powered portable suction unit using to remove stuff immediately from the patient's airway. So blood, vomitus, fluids, and whatnot. Obviously, a suction device is going to be necessary. In most cases, if we have a hard suction tip, that's what we're going to use. Tends to clear things a little quicker. We may then consider inserting an oral adjunct. They're completely unresponsive. You could put a nasal adjunct in, but an oral adjunct should work just fine. The oral pharyngeal airway, or the OPA, we're going to insert it in most adults upside down till we almost touch the roof of the mouth and then rotate 180 degrees. In kids, we may put it in sideways and then rotate it 90 degrees, or we may use a tongue depressor to hold the tongue in place and insert it. Additionally, if we have the apparently unresponsive patient, if we haven't used the adjuncts as we've looked at the previous pages, also assessing breathing. So after we've cleared the airway and we've opened the airway, we obviously want to look, listen, and feel for any breathing. We maybe have done this prior to doing some of those other techniques because that's what we did to make a judgment call on the